Hello, everyone, and welcome to HeadWise, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. I'm excited to tell you that I am here today with a brand new guest that has never been on HeadWise. This is Dr. Andy Russo. Hello, Dr. Russo. How are you?
Great, thank you.
Dr. Russo is a professor of molecular physiology, biophysics, and neurology at the University of Iowa. He has published extensively in the migraine field and most recently has published on both CGRP and PACAP and their role in migraine. Today, we're going to focus on something called PACAP, or Pituitary Adenylate Cyclase-Activating Polypeptide. This is one of the molecules that is being looked at as another drug target for migraine. And I think we all want to hear about our next drug target. So I can't wait to hear what he has to say. So thank you for being here, Dr. Russo. Since you've not been a guest on HeadWise before, can you please tell our audience who you are and why you are so motivated to work in this field?
Yeah, first off, thanks so much, Lindsay, for giving me a chance to talk about one of my passions, which is CGRP, and now the evolution of the field to include PACAP as well. How did I get into this? Well, there's really two directions. The one that I really should say first is that I have two daughters who have really bad migraines, and so I live firsthand. I've lived firsthand for many years with people with migraine, and I know how debilitating it is and how awful. So that's first foremost one of the, I guess, things that drives me to want to find a cure. But to be totally honest, I didn't start out working on migraine. I was working on the neuropeptide CGRP, and quite honestly, migraine was not the reason why I was working on CGRP. I started on CGRP before we had any indication is involved in migraine. But I got into the migraine field because of a ski trip. I was riding on a ski lift at a ski meeting, and I thought, I've been working on CGRP at that point for well over a decade and knew about its role in migraine being speculated upon. I thought maybe there's something I can do as a basic scientist with mice or rats, ended up working with mice only, with mice to try to figure out just what is CGRP doing that could be causing a migraine. So combination of personal interest from my daughters and scientific interest, because of that's one of the beauties of being a scientist. We can ask weird questions. In this case, a question inspired by being at high altitude at Breckenridge and on a ski lift. I figured, let's give it a go. So that was back in the early 2000s, and it's been an exciting journey, I got to say up front. Been very exciting.
That is an amazing story. I did not know that story. Thank you for telling us. It also brings in my home state. I am in Colorado. So I love that you got to loop in your personal life and your family life and what you do for a living. And what a great story. So it's kind of special that we got to hear that. So you've done a lot of work on the CGRP pathway. A lot of people in our audience found relief with these medications and are very grateful for them. And there are also many who did not. So before we get to PACAP, my first question is actually going to be related to CGRP. Do you feel we've exhausted the CGRP pathway when it comes to drug targets for migraine? Or is there more we can learn in order to make a more effective migraine medication related to this pathway?
That's a great question. The answer is very short. No, we have not exhausted the pathways for CGRP to be targeted for therapeutics. I will give a big plug for my favorite pathway that hasn't been looked at, and that's within the brain. Drug companies are hesitant to have a drug go into the CNS, and understandably so. Our brain is precious, and we don't want to muck it up. And there is a risk of side effects whenever you start mucking up the brain. I think it's going to be totally reasonable. And this is just prediction. I don't know for sure, of course, but based on work we've done with mice, I think that it's very reasonable that we can dampen CGRP activity in the brain and reduce migraine symptoms. The reason for that is that right now we know that the CGRP drugs are mainly acting in the periphery, outside the blood-brain barrier. And I want to put a caveat on that we are not 100% sure. That's part of science. There's always caveats. There could be a very small amount of the drugs getting across the blood-brain barrier that are having their effects. Certainly that's a possibility. We know from our mice that there are different sites of CGRP action outside the brain and inside the brain that both can lead to similar symptoms that are migraine-like behaviors. Light aversion for photophobia, cutaneous allodynia for touch sensitivity, and grimace for spontaneous just pain feeling. So, long answer, you get a professor talking, they don't stop talking. Short answer is yes, I think there's more future for CGRP drugs that we have not exhausted the potential for their actions. And the major area we need to look at is inside the brain. So that's what we're looking at now with our mouse models. And we've shown that the CGRP blocking drugs, when injected into the brain, appear to be not having side effects on the mice. Of course, we need to next go to people and make sure that they work there.
Interesting. So just out of curiosity, because I think a lot of people are going to wonder when you said that you're injecting them into the mouse brain, would the idea in a human model be more like making a really small molecule that would cross the blood-brain barrier? You wouldn't necessarily be injecting it into a human brain, correct?
Right. Correct.
Okay.
And part of the excitement on this, and I'm going to get ahead of myself here towards the future directions beyond CGRP and beyond PACAP, which I do want to talk a lot about PACAP mainly. But if we can find out where in the brain CGRP is acting, then we can start having more targeted transcutaneal stimulation. So using neuromodulators that not enter the skull, but still send signals to the brain to then potentially help migraine. And so I'm very excited about the small molecule potential. They're more lipophilic, could cross the blood-brain barrier. And most excited about that, but also the potential eventually of the neuromodulators to be able to know where to target activity.
Okay, so it's also helping you find the location where these molecules are actively helping migraine, correct?
Yeah.
All right.
Because that's something we can do in mice we can't so easily do in people to start the circuitry figured out.
All right. This is awesome. We don't often get to talk to someone who works in science. So I think that our audience is going to find this very exciting.
That'll get a headache. One or the other.
A lot of them might already have one. So we're probably in a safe zone. So moving into the topic of the day, why don't you talk to us and just tell us what PACAP is? This is the other molecule that we mentioned that is looking like it could maybe be another promising drug target.
Yeah. So PACAP, like CGRP, has a just awful acronym. It's Pituitary Adenylate Cyclase-Activating Polypeptide. Seriously? I mean, who thought that up?
Yeah.
It's like, the name, though, gives you kind of a clue of what it does. It activates a signaling pathway involving adenylate cyclase, so making cyclic AMP, that is similar to what CGRP does. And so getting into the comparison of CGRP and PACAP, the initial thought was, well, maybe PACAP's just a CGRP wannabe, and they'll be acting similarly. I think that to some extent has held true, that PACAP can induce migraine in migraine patients, just like CGRP can. But what we've done is we've now, and other labs, have dived a little bit deeper beyond that superficial but very important similarity. They're both causing migraine. To ask, are they acting in the same way? Are they dependent on each other, or are they independent? And the comparison of what this peptide with the awful acronym PACAP is doing with what CGRP is doing at the molecular level, when you start looking at that level, drilling down deep, there's similarities but differences. So I can't say for sure if the differences are important for PACAP actions versus CGRP actions, but we know that we have a cast of different pathways that they can take, and they're not identical pathways. So moving forward in the field, we and others want to do is try to figure out which pathways are important for each of their activities. Is it the one shared cyclic EMP pathway that they're using? I don't think so. From what we've done with mice and other labs have done with mice, from what we've seen with the symptoms reported by patients, I don't think they'll be the same. And the final reason why I think they'll be different is they're expressed in different parts of the nervous system.
Okay.
GRP is mainly in the trigeminal nerve. PACAP is mainly in the sphenopalatine ganglia and those parasympathetic nerves from that ganglia. So different ganglia, so different parts of the nervous system.
Can you really quickly tell our audience where the sphenopalatine ganglia is?
Somewhere in here.
It's more central than the trigeminal nerve, which is where you said CGRP was.
They're both in the periphery. They're both in the peripheral nervous system.
Yeah.
They're not that far apart. And I don't really know how to point on my body without taking my head off.
It's up here and here.
They're both up here. They're both up here. So actually, I teach med students, and right now they're learning neuroanatomy. But with cadavers, it's a lot easier to point it out on a cadaver than a person.
Okay, go ahead. I didn't mean to interrupt.
So they do overlap. There's some PACAP in the trigeminal nerve and the sphenopalatine nerve talk to each other. So just because they're in different real estate doesn't mean they're necessarily not working together or not doing the same thing. But I think it's another clue, along with our preclinical mouse data, that they work independently.
Okay.
At different ways.
So the two molecules, CGRP and PACAP, they mostly work in different areas, but they're both areas related to migraine. So I think that's probably the most important point that we were just making to summarize it, correct?
Thank you. Yep.
So some companies are already investigating PACAP as a drug target for migraine. Do you think it looks promising for us that this could be another drug target, kind of like CGRP?
Absolutely. So we are all waiting with bated breath for Lundbeck, a Danish company, to announce the results from their phase 2 clinical trial with a monoclonal antibody that binds PACAP. Okay. Similar to the monoclonal antibodies that bind CGRP that have been so effective as preventative drugs for many people. Not all, but many people. So the trial results are very similar in terms of the efficacy of the PACAP antibody in reducing the number of migraine days suffered by people with migraine per month. So that's very exciting, very encouraging. The details of that were just released about 2 weeks ago in Seoul, Korea at the International Headache Congress. And there's a lot of excitement there about this. So moving forward, Lundbeck is now setting up phase 3 clinical trials to really nail down the efficacy. And I think it looks very promising. It's the hottest, it's the newest kid on the block, and it's the hottest kid on the block right now in terms of potential for helping migraine patients. I think that the biggest question, though, again, will be, will the people who are not helped by the CGRP targeted therapies be helped by this PACAP targeted therapy? We don't know the answer to that. It's purely speculative based on what I said earlier about their similarities and differences between them. I really think that they will be acting on different mechanisms and migraine. So I think that they will potentially help patients who don't get help right now with the CGRP drugs. Okay. Conversely, I think there will be overlap. Some people who respond to CGRP drugs will respond to PACAP drugs. It's not going to be an either or. It'll be like two circles overlapping. But I'm really hopeful that the PACAP drugs will work with people who don't respond well to the CGRP drugs.
I think a question that's been on my mind ever since I first read about PACAP and its possibility as a molecule that is affecting migraine is it possible that a really good therapeutic or drug could come out that targets both pathways? And I'm wondering if that is something that people could work on in the future.
Absolutely. I think that combinatorial therapy is a no-brainer, actually, for migraine treatment. Migraine is not due to any one single molecule. And it's, I think, remarkable that the CGRP targeted drugs have worked as well as they have. So it makes a lot of sense to me that if you combine drugs targeting CGRP and PACAP, that you'll have more efficacious treatment, so better response among people who respond to one or the other. And so the analogy I use for it is a football analogy. So we're in football season here in Iowa. We're a Big Ten school, and this Iowa City lives and breathes on the Hawkeye football games. The town goes crazy every week with the game. So the analogy I have, I think, is appropriate for not just Hawkeye fans, but if you're not a Hawkeye fan, you should be a fan. It's like having someone covering a wide receiver with the CGRP antibody, going for the long shot, ball being thrown to the receiver, but also having somebody covering for the run. So waiting for the running back to do an end run around the line. I think that is the way I kind of view the drugs that are targeting the peptides as opposed to drugs that would target a neurotransmitter. A neurotransmitter blockage may be effective for migraine, but I'm more worried about that because that's more like the football analogy. The defensive line there, it's a solid line blocking, and the quarterback may try to sneak through, but he's not going to get very far running through the line. Okay, yeah, you can get through the line definitely, but by blocking that line, you're really cutting down all information flow across that, blocking that information flow. The drugs blocking peptide action, hitting the wide receiver or hitting the running back, going around the line, those are getting the extra flow of information. And then the analogy kind of breaks down a little bit there. I'm sorry. I'll keep working on it. But by blocking the running back, you're going to hopefully cover up something that blocking the wide receiver did not do. And so by having both drugs on board, you're more likely to get these two mechanisms.
Right.
Possible migraine transmission.
Right.
Yeah,
so
the
drugs that block the peptides are more specific. Is that part of what you're saying with this analogy? Than the ones that block the neuropeptide, the neurotransmitters. Excuse me. And so it's part of why we have less side effects, perhaps, with the ones that block the peptides. Yeah. And we would possibly have the chance to block more than one peptide at a time and do a better job, which is where the question first started. I actually do like that analogy. That was great. So
my colleagues who work on neurotransmitters would get their hackles up about saying their drug's not as good, but there you have it. So there's risk with every drug. So I don't want to sugarcoat the risk with CGRP and PACAP drugs. We're very, very aware, but so far they've been the CGRP drugs, and from the phase 2 trials, the adverse effects with the PACAP antibody have been remarkably minor. There are definitely some side effects, but the target, I mean, you listen to the target side effects on anything advertised, and they list out all these horrible things and death. Well, that hasn't been the case with the CGRP target therapies, at least so far. So I'm happy that they've been relatively safe. And I think a lot of it is because of the mechanism of neuropeptide action, that they're modulating activity. They're not the key transmitter, but they're the ones that give the added boost to a
Right.
signal.
Interesting way of looking at it. I think that's an awesome analogy and a great point that I actually had not thought of. So we have covered that you don't believe that we've exhausted all possibilities for medications in the CGRP pathway in migraine, that PACAP is a very promising molecule in migraine as a drug target, and that the pathway is promising, and that even putting the two together could be promising. Is there anything else that you would like to cover having to do with these two pathways, as someone who's written quite a bit? And I have read your papers and I'm very impressed and I love them. Is there anything else that you would like to add before we go today?
I think that a lot of it is figuring out what your trigger is and avoiding the trigger. The answer is not all with drugs, but sometimes we just can't avoid those triggers. One of my daughters, her trigger is stress. And I told her, well, just don't get stressed. You imagine how well that went over.
Yeah.
So it isn't that easy to avoid the triggers, but if you can minimize the triggers, that's a place to start with lifestyle modifications. So I think that's what I encourage people with, is to try to take a combination of the pharmaceuticals and the behavioral modifications, if possible. That sounds a little bit like a preacher, and I don't want to sound like a preacher, because and I said with my daughter, it's easy to say, don't get stressed, but sometimes you can't avoid those triggers. In which case, what I'm excited about is the second aspect of migraine is that it's been socially a stigma for so long to admit that you have migraine, because it's seen as a weakness. It's, I think, unfortunate, but that stigma is still out there. I'm real excited by the fact that by identifying a neuropeptide, CGRP, as being so crucial to the process, that we're hopefully taking migraine beyond the fuzzy, well, it's just a headache business. Oh yeah, this is actually a neurological disorder. And it is a neurological disorder that involves the imbalance of signaling, most likely, in different parts of the brain, as well as signaling in the periphery as well. So I'm hoping that we can get beyond the labeling of it as being just another headache or just a headache, to understanding what's going on. And my last thought of it is just more of a scientific curiosity, to bring it back around full circle, that I think that migraine is giving us a clue to how the brain deals with sensory processing. And CGRP is increasing, I believe, that transmission of information from light, sound, touch, smell, even interoception, being aware of your body. And that's pretty cool. It's pretty cool. So how is CGRP doing that? And maybe migraine is a consequence when you get a little bit too much of that sensitization to sensory input, which is also, I think, intriguing, that the body kicks in this pain mechanism, perhaps as a protective step, so you don't have too much sensory input. So I just want to bring it back full circle as a scientist, and as a father of daughters with it. I see the excitement for me is both helping people with drugs and also with lifestyle, and secondly, to understand how our brain works and processing information. And migraine's given us an opportunity to try to figure out how that's working.
That was a very great way to end this episode. Thank you for that. We don't very often get to hear the viewpoint of a scientist working in the field of migraine. So I want to thank you so much for being with us today. That was an awesome new perspective that we have not really had before. So thank you to you, and thank you to everyone who joined us today. And please join us again next week for the weekly videocast and podcast of the National Headache Foundation.
Great. Thank you. Bye.